Welcome everyone to the Careers Webinar series Immunology. We have two great speakers and I'll be introducing you to our hosts who will tell you more about them shortly. I just wanted to introduce the Royal College of Pathologists, just in case you're not aware of what we do, the work we do. I'm Penny Fletcher. I'm the Corporate and Public Engagement Manager at the college. Not a pathologist or clinical scientist by background, but have learned a lot since I started working there. Really fascinating place to work. So we're the professional membership organisation, and we have charitable status. So we have around 12,000 members. So these are pathologists and scientists working in 17 different pathology specialties. So most of our members work in hospitals and universities in the UK, although we do have a good number working in other countries around the world. So a wide range of different countries and membership there. The core part of our work is that we oversee training exams and professional standards across pathology. And the other area of work, one of the other areas, is that we tell the public about pathology and we look to inspire the next generation, which is what we're doing today. So welcome to, in fact, it's our 8th Pathology Careers Webinar. I need to update that slide. We actually had our 7th last week, which is also in immunology, but we're having a second one, which will focus on the clinical scientist training pathway. So I'd like to hand over to our two brilliant hosts who are joining us for the first time, and thank you very much. So they're both undergraduates, so Hayagriv Rambarath and Victoria Manukan, both at the University of Manchester, and they're going to introduce themselves and then our speakers. So I hope you enjoy the webinar. Thank you.
Hello, my name is Hayagriv, and I'm pleased to be introducing our two speakers today. Kavindi Gunaratne is a senior clinical scientist in the Immunology laboratory at Derriford Hospital, Plymouth, and Kristen Lilly is a consultant clinical scientist at Sheffield Teaching Hospitals.
And hello, I'm Victoria, and I'm looking forward to hearing from our speakers today. And just a reminder, if you have any questions, you can just put them in the Q&A section, and we're going to go through them after the presentation.
Cover just an introduction to what clinical immunology is, the roles within the clinical immunology lab, the scientist training program, which is how I got into this role, and a bit about what my day-to-day role involves. So what is immunology? As you guys know, I assume, it's the study of the immune system, which is a complex system of specialized cells, tissues, and proteins, which make up our body's defense against infection. So our bodies are constantly exposed to threats from bacteria, viruses, and other pathogens, but the immune system kicks in when these threats bypass our physical barriers like our skin and our mucosal linings. And our immune system is constantly working all around the clock to maintain your health. And as well as protecting us against pathogens, the immune system is also activated by abnormal or damaged cells as well. So, as I said, it's made up of various different organs, tissues, cells, and proteins. So the organs include your bone marrow, so that's where most of your immune cells develop from, stem cells that come from your bone marrow. You also have your thymus, which is where some of your lymphocytes mature, so your T cells, and various other organs such as your spleen, which filters your blood, and lymph nodes, which filter your lymph fluid. All of these different organs have various different immune cells in them, and yes. So in terms of cells, so as I said, the large majority of your immune cells are derived from stem cells in the bone marrow, but you have immune cells found all over your body, so in your blood, in the lymphatic vessels, in the lymphoid organs, as I said, or in your tissues. The different immune cells have different roles, but the kind of things they do are direct killing of the pathogens, or virally infected cells by inducing cell lysis, or phagocytosis, which is engulfing and digesting the pathogens. Some cells, like T cells, also release cytokines to communicate and activate other cells. And finally, your protein components. So you have your antibodies. These are made by your B cells and plasma cells, and they are specific to an antigen, and they neutralize, agglutinate, pathogen. They also flag pathogens, mark them out for phagocytosis, and activate something called your complement system. Your complement proteins are plasma proteins, oh no, made by your liver, and activation of these proteins perpetuate the inflammation that you see in infection and inflammatory diseases, and also causes cell lysis, which is how it functions to get rid of your pathogens. And finally, as I've mentioned, your cytokines and chemokines are your small proteins that enable cell-to-cell communication. So all of these cellular and soluble components of the immune system work together to coordinate the immune response. So there's three main aspects of this. So it requires the immune system needs to recognize the difference between self, so your own antigens, and non-self, so foreign antigen. It also needs to be able to respond. So I've mentioned various different cells and proteins that eliminate the pathogen and or the abnormal cells. And once this inflammatory immune response has gotten rid of the pathogen, you need to be able to dampen down the immune response to restore normal tissue homeostasis. So what is clinical immunology? So this is a study of diseases of the immune system when all of those things that I've mentioned goes wrong. So one thing is, for example, when you're missing parts of your immune system or parts of your immune system aren't working, you are unable to respond defend yourself against pathogen infection. So that leads to immunodeficiency. So some of you guys might have heard of severe combined immunodeficiency, which is a life-threatening condition that requires urgent action. So kids are born without T cells, which are required to coordinate your entire immune response, and patients are really susceptible to very severe, unusual infections, and without treatment, they will not survive beyond a couple of years. Also, an inappropriate response to antigens within your own body. So you're not supposed to respond to self-antigen, but in autoimmune diseases, you do. So you may know about rheumatoid arthritis and lupus, which are examples of autoimmune diseases. An inappropriate response to antigens that are harmless. So allergens such as foods, so peanut, drugs such as penicillins and venoms, so bee and wasp venoms. They're not supposed to be harmful, but an inappropriate response to those is what we call hypersensitivity and allergy. And finally, when your immune cells themselves undergo malignant transformation, so leading to malignancies such as leukemia, lymphoma, and myelomas. So clinical immunology is one of the 17 specialities within the Royal College of Pathology, and this discipline covers both the medical aspects and the immunology laboratory aspects. So what do we do in the clinical immunology lab? So in the lab, we analyze serum and plasma, whole blood, urine, fluids, and bone marrow samples to diagnose and monitor these immunological diseases. So just to explain what serum is, so whole blood is the state that you find blood in the body, so it contains your red cells, white cells, platelets, and the yellowish fluid, which all of this stuff floats around in, which is called your plasma. And your plasma contains your water, it's mainly water-based, but various different things dissolved in it, such as your proteins, which includes your antibodies. So when a lot of our immunology tests are looking at these proteins directly, so we're measuring serum, and some of our immunology tests are looking at whole blood, where we're counting the numbers of white cells. So the techniques that we use for these measurements in the lab also use components of the immune system. So we use antibodies as reagents. And the immunology lab we generally divide it into the following sections. So we have autoimmunity and allergy. So that's looking at proteins that are causing us harm. So with autoimmunity, we're looking at autoantibodies, and with allergy, we're looking at IgE specific to allergens. In protein chemistry, we're looking at proteins in general. So proteins, specifically antibodies, are they there? How much do we have, and do they work? And flow cytometry, so that's looking at your cell populations, your different white cell populations. So autoimmunity, as I said, detection of autoantibodies. So one of the techniques we have is indirect immunofluorescence, where we have a bit of tissue or cells on a slide. We put the patient serum onto it and a fluorescent marker and look at it down the fluorescence microscope. And we get various different patterns, and we can interpret accordingly. So, for example, detecting antinuclear antibodies, which is often positive in systemic lupus erythematosus. So this is the kind of pattern you would expect to see there. ELISA-based techniques as well, they're really common in the autoimmunity section. So you guys probably have heard of ELISA techniques, but we use it to detect TTG antibody, which is seen in celiac disease, CCP, which is seen in, used for the diagnosis of rheumatoid arthritis, and TSH receptor antibodies, which is used for the diagnosis of Graves' disease, a type of autoimmune thyroid disease. So allergy tests use a very similar methodology. It's basically an ELISA-based method, but using fluorescence instead. And as I said, we can detect specific IgE to hundreds of different allergens, and also mast cell tryptase, which is a mediator that's released during an allergic reaction. So protein chemistry, as I said, we're looking at our proteins, i.e., are they there? Are they in their normal number, and do they work? So what we can do with our serum is run it on an electrophoretic gel or capillary, which basically separates out the proteins by size and charge. And we get a nice separation here of your proteins into different regions. So this is your albumin region, and this is where your immunoglobulins migrate to. And we can see abnormalities such as monoclonal antibodies. So you would see that in multiple myeloma, which is a malignancy of plasma cells, where you have a clone of plasma cells that are producing monoclonal antibody, and they all migrate to one specific region, and you get a nice peak here, which is not very nice for the patient. Other techniques are done in protein chemistry as well, but in our lab, this is the bulk of our workload. And flow cytometry. So here we're looking at immune cells, and for immunodeficiency, we're looking to see if the cells are there in the correct numbers, the correct proportions, and if we can also do functional studies to stimulate the cells and see if it's doing what it's supposed to and working in the way it's supposed to. We also use flow cytometry for hematological malignancies, so for leukemias, lymphomas, and myeloma. So we're looking to see, is an abnormal population there, and what does that look like? How can we characterize it? So who works in the lab? So there are various different roles within the clinical immunology lab. I didn't realize this before I started working here, but you have ranging from consultant medics and clinical scientists who are heavily, who do the interpretation and reporting of complex results. They also have overall clinical responsibility for the lab, for quality as well. You have the biomedical scientists who are science graduates, so generally graduates of an IBMS accredited degree. They've done their portfolio and they're state registered as a biomedical scientist, as is a clinical scientist. I forgot to mention that. And they are technical specialists, and they oversee the quality of the tests that they do and the day-to-day running of the tests. And generally, the first stage of reporting results is done by a biomedical scientist, whereas the second stage is done by clinical scientists or medics. You also have associate practitioners and medical laboratory assistants. So associate practitioners are more senior than medical laboratory assistants, but they both support biomedical scientists in the day-to-day running of the lab. So things like maintaining the analyzers, making sure there's enough lab supplies, labeling samples, etc., etc. So we're going to focus on clinical scientists because that's what this webinar is about. But generally, clinical scientists have roles within a large variety of healthcare disciplines. So this immunology is within life sciences. You also have other life science disciplines like biochemistry, reproductive science, all sorts that pathology falls into, but you also have physical sciences, so medical imaging, physiological sciences, which cover respiratory science, cardiac science, and informatics, which is sort of bioinformatics, that kind of thing. So as you can imagine, the roles vary from patient-facing to non-patient-facing. So the lab roles are generally not patient-facing, and the physiological sciences, you're doing the tests on the patient, so it is patient-facing. So the main entry route to become a clinical scientist is through the scientist training program, which I'll touch on for my discipline. But there is also STP equivalents, which scientists, let's say in the lab, who have significant amounts of experience, if they can demonstrate they have the clinical experience that's mapped to the training program, which I'll touch on more later, they can register to become a clinical scientist. So the training pathway in immunology, like I say, you do the scientist training program, where you are a trainee clinical scientist, and once you finish that, you are eligible to register for on the Healthcare Professions Council, HCPC, as a clinical scientist and start working as a senior clinical scientist. So this is the stage that I am at now. Once you have done your fellowship of the Royal College of Pathology, Part 1 exam, you are eligible for principal clinical scientist roles. And once you have completed your full fellowship of the Royal College exams, you are eligible for consultant clinical scientist roles. You can also do something as a further high specialist scientific training program, which Kristen will touch on later, which covers some of these aspects, but some more as well, which will make you eligible for consultant clinical scientist roles. So how did I get into this role? So I've always been interested in science. I always wanted to use science to help people. So I thought medicine was the only way to do that, until I realized that I didn't want to be patient-facing when I did some work experience back in during my GCSE years. So I went into biomedical sciences thinking that that's the only, research was the only option for me. I decided to do developmental biology. I did an internship at an aging lab, which we worked with C. elegans worms, but I found it way too academic and I didn't really enjoy that aspect of things. But in my second year, I did a literature review on a immunological disease and immune-mediated treatments for it, which really sparked my interest in immunology. So then I started doing immunology modules. I did my research project in my third year. It was a flow cytometry-based project, and I was looking at stress-inducible proteins in B-cell subpopulations. And when I was in my third year, that's when I stumbled across the scientist training program. So what is the scientist training program? It is a 3-year postgraduate program of mainly work-based learning, but it's also supported by a part-time accredited master's degree. There are different routes into the STP, so direct entry, which is what I did, is when the employer, the hospital, the training hospital, puts out a post and anyone can apply to it, provided you have the right qualifications. Generally, it's just minimum an undergraduate degree of 2-1 or higher grade. But people come into it from various different backgrounds. So they may have come in from industry, they may have come in from academia, they might have done, like if they were in academia, they might have done, a master's, a PhD, worked as a postdoc for a couple of years and then come into this, or they might have come straight after uni like I did. There's also in-service, which is when you are already working in the hospital, that in the lab that you the training post will be going out for. But yeah, so what the training is, so it's basically you're supernumerary, and which means you're in excess of the normal workforce. And I had to complete a portfolio of work-based modules. So in my first year, I did rotations across a lot of 4 different blood science disciplines, which helped me gain an understanding of the different pathology disciplines and how they all link together, and with immunology. My second and third years focused on specialist immunology modules. So mainly practical interpretation and clinical learning that underpinned my work-based modules. So I had to demonstrate competence in all of these areas. And I also had a module that was about professional practice, clinical leadership, and all of those soft skills that you need in a clinical scientist role. So the kind of things I did, so I did have a training budget that supported the academic element of the STP, so helped me go to Manchester and complete the Masters. I was able to use some of the extra money for placements at other immunology labs, to go to conferences, network meetings. I tried to do as much extracurricular stuff as I could fit in. So I was the joint network lead for a regional STP training network, which basically provided support and education webinars and stuff like that for the regional STPs. I also got to do a research project, which was bringing in a new test, an autoantibody test for a neurological disease. And finally, last year, I completed the program, which made me eligible to register with the HCPC as a clinical scientist, and I started my role as a senior clinical scientist in Plymouth in October 2023. So in terms of what I do, this is really difficult to explain, but no 2 days are the same, basically, and I'm sure Kristen will go into this as well. But day-to-day interpretation and reporting of the results. So if you remember the pictures I showed you earlier, I look at those on an almost day-to-day basis. IQC troubleshooting, so that refers to internal quality control. Basically, we run a sample of known concentration on our machines every day, and it just tells us if the machines are working or not, and if they're not looking good, then we need to look into what's caused that and what that means for our patient samples that we're also running. Maintaining accreditation standards. Teaching and training is a large part of the role as well. So this covers from medical students to BMSs to trainee clinical scientists as well. So yeah, user inquiries, so emails, phone calls, someone's asking about interpretation, advice on test results, what tests to request, stuff like that. And odds and sods, so I like the same, but basically anything that anyone in the lab or somewhere else doesn't know what to do about, it's if I'm on duty that day, it's for me to try and figure out what to do about. So that's a lot of fun. So yeah, I think that's the end of my bit, and I'll hand over to Kristen.
Okay, so hi everyone, thanks for joining us. So I'm Kristen Lilly. I'm a consultant clinical scientist currently based at Sheffield Teaching Hospitals in the Northern General Hospital. And Kavindi's really given us a great introduction to what clinical immunology is and a bit about the STP as well. So I'm just going to talk a little bit through my personal journey to becoming a consultant clinical scientist. I'll specifically go into some more detail about HSST training, which is a fundamental reason and infrastructure behind how I've got to where I've got to today. Again, I'll just briefly touch on day-to-day work, which Kavindi's already mentioned, because it's never really the same every day. And then how that fits into the bigger picture, where immunology stands in the national front and how we can contribute to that. And a final slide on just what I've found through my journey have become my special interests and what's open to you if you were to go down this type of career path. So to start it off with my personal journey, I finished high school in 2008, which seems like a long time ago now, and started an undergraduate degree at the University of Strathclyde in Glasgow. So that undergraduate degree was in immunology and pharmacology, and it was 4 years, which is standard within the Scottish university system. But as I got to the end of my 4th year and realised that I hadn't necessarily been preparing for what's next to get onto the career ladder, I applied to transfer onto an undergraduate master's course, which then focused on the immunology side of things. So that was to take me on to do a 5th year and undertake a further research project and take on some additional skills, basically, that degree gave to me. So that finished in 2013, and I was able to graduate with that undergraduate master's degree. At which point, during that year, I had a little bit more time to then think about what was next. And similar to Kavindi, I stumbled across the scientist training programme, which looked to be perfect. Based on personal preference, the industry in pharmaceuticals wasn't really something that appealed to me. I wasn't greatly enthused by the research setting at that time. And also I wasn't really enthusiastic about becoming a patient-facing healthcare professional. It wasn't something I was interested in. So the scientist training programme really offered a fantastic opportunity to be involved in the healthcare setting, be involved directly in patient pathways and patient care, but not having to do that patient-facing role. And it probably goes a little bit unrecognised at times as well. So yeah, I finished training, applied to the STP, and was thankfully able to get on. Similar to Kavindi, I had applied to a direct entry post, which was Plymouth I was allocated to, believe it or not, which was an excellent opportunity and I was really excited about. And then I checked out what the map was looking like for me to get down to Plymouth. But this was it. It was the beginning of the real world journey and life after university, which was very exciting. So I packed up the car and off I went to Plymouth. I started at Derriford Hospital in 2013 to begin that 3-year training programme. It was an excellent opportunity. Really enjoyed working within that team there, and thankfully was able to complete my training, and they decided to keep me around for a little bit longer when I had applied for a job and was successful at interview. So I then started the senior clinical practice scientist post in 2016, but naturally was already thinking about what was the next steps as a clinical scientist, what was the next challenges, where did this road take me to? And that naturally took me on to the higher specialist training route. And the department kindly supported applying for a position within the trust, and this was then an in-service post that they applied for and I was able to get onto. So started the higher specialist scientific training in 2017. And as Kavindi's already mentioned, there's various avenues of that. One part being the FRC Path exam, which I'll explain a little bit later, but managed to get the FRC Path exam, which allowed then me to progress to a principal clinical scientist role in 2018. And then went on to finish the higher specialist training and managed to be successful at interview for a consultant clinical scientist post in 2022 in Sheffield at the Northern General Hospital. So it was a very interesting route to take. And part of what I was hoping to discuss with you all today then was probably a little bit more detail behind that higher specialist scientific training. Now, I understand as undergraduate scientists, the STP is the next logical step, but I think this would be an excellent opportunity just to show you how far this can go and the support and infrastructure that's in place if you do choose to go down this career pathway. So what does it involve? It does involve quite a lot of work, but naturally, as you progress, if you're progressing through the STP and in that clinical scientist role, it does become work that you enjoy and work that you want to continue progressing in and you want to continue to have an impact in. It's a really challenging 5 years, but as I've said, if you're motivated enough in those roles, it's really worthwhile. You get funding allocated, which Kavindi's touched on how helpful that was in STP. It was extremely helpful in HST because it allows you to attend certain conferences, attend certain learning opportunities, and also fund some research, which you have to do as part of the course. And I know that 5 years sounds like a long time, but it does. It's a busy timetable. It's very condensed with what you have to achieve during that time. So it does fly in pretty quickly, and it can be challenging but enjoyable. So just to quickly get a brief overview, a breakdown of what that 5 years included. So this is the 4 main elements of how I completed the HSST training programme. This is quite a standard approach and a lot of people do it this way. There are slight deviations that can be made based on your background and your experience, and I'll touch on that just a little bit at the end, because of course people come into these roles with very different backgrounds, and they want you to get through these roles. They don't want to make things difficult. They want to support what you've already done and make sure you can get through this post. So the first part, which is quite similar to STP, it's a bit of an online portfolio, and this is mapped against what's called proficiency standards for highest specialist scientists. It's basically a set of standards that we have to demonstrate that we adhere to and that we can meet. And it sounds awfully complicated, but it's not so bad actually. If you look at the domains which these standards fall in, you think about things like professional practice, scientific practice, and clinical practice. This is all part of what we do in the routine daily work. So it's just a case of reflecting and writing up that work that you already do and submitting that as an evidence-based competency for your portfolio signed off. And during the process, you do have a training officer who is involved in helping you identify how to achieve these standards and also signing off the work that you do so that you have an independent person marking you through that process. The research element of it is quite useful as well, and you do have an opportunity to achieve that anyway as you do a doctorate project within the higher specialist training, which I'll come on to in a second, so that was helpful. And then the clinical leadership is quite an exciting part of it, because this is where you are really starting to demonstrate that you're meeting or performing at a consultant grade level within the healthcare setting. It's about practicing based on evidence-based practice and ensuring that your service is doing its best by the patient, really, based on national and good practice. So that's the online portfolio, a bit of a whistle-stop tour of that. The other element of the HSST is the postgraduate diploma in leadership and management within healthcare sciences. Now, this was probably one of the, I'd say, the most uncomfortable parts of it to begin with, and that's because we are built as life scientists in a certain way. We test theories, we test hypotheses, we write our papers and our work up a certain way, and social sciences challenges that a little bit. It's a little bit more insightful about yourself and about the system as a whole. So it comes as a really valuable tool to be able to take you as a life scientist or a biological scientist and put you into the healthcare setting at a senior level where things are very intertwined and it can be quite a complex environment that you're in. So you can see from some of these modules that we had to complete that there's a lot of elements of leadership and management in there. Like I said, it was challenging, but probably the most valuable part of the HSST training, and that's because it really drives you when you get to a certain level within the healthcare setting, especially within the hospitals. You're really driven and really bound by the processes and the resources around you. We all know about the challenges associated with the NHS, and we really have to try and get the best out of it with what we have. So to do that, we really have to understand the system itself and the limitations around that and how we can help regardless, or how we can push innovation and change through. It also gives us this ability to understand your colleagues and the user groups of your service as well. We can understand what drives those groups and we can interact better in them to get a better outcome. But more importantly, it gives you a better understanding about yourself in this environment. And it's something that when you're going through a kind of undergraduate level and you're progressing through, I don't think there's there's not a lot of tools available to help you develop in this way. And it's so essential for when you get to that healthcare setting within the hospital. So it was a really valuable aspect of the higher specialist training and necessary. The next part is a little bit more hands dirty science, and that was allowed us to kind of get back to the bench and get back to making hypotheses and setting up real research projects and things. And that was a doctorate in clinical science qualification. So this is a doctorate level project, and it's now called a DClin Sci. You would graduate at doctorate level with that, and you had to meet the standards of a doctorate. But the nice thing about it was that the write-up actually wasn't as long as a typical traditional PhD. Just for example, a PhD could be excess of 100,000 words, whereas these could be about 20 to 40,000 words. So that was very appealing to someone like me. The funding which you have as part of the HSST is really invaluable for this doctorate because it gives you avenues to explore research and not be restricted in a certain way by what's available to you. Part of it was a personal objective of mine when I was doing this, was to not just stay siloed on my own and try and build a research project within the lab. I wanted to reach out to other disciplines within the hospital and join a group or participate in a group with an established research team and a research infrastructure in place. And that funding that was available really allowed for that to happen. I managed to hook up with the Plymouth Hepatology Research Group, which was an excellent group full of scientists and researchers of different levels, which I was able to join, excuse me, and it really gave a real true experience of getting back into research and doing the fundamental work and building methods up from scratch. So I was very grateful to be able to do that, and that's the title of the project which I undertook and managed to write up a couple of years ago now. It was. The other valuable aspect of this, and talking about meeting the other elements of HSST, is being able to reach outside my own team and collaborate with other users within the hospital. It really set up some working relationships, which myself and the department continued to use after this project was gone. Immunology is a small-ish discipline, but it's linked with so many other disciplines within the hospital setting that you do need to be able to build that network of people to be able to discuss with. So that was a really valuable aspect. Now, finally, as we've touched on, we've got the Royal College of Pathologists Fellowships exams, which is probably one of the most daunting parts of the whole process. These exams are set and are sat by both in immunology, sat by both medical colleagues and scientist colleagues. So we work together in trying to sit these same exams and work towards consultant level. The part one happens quite early in the training. So that happens, as mentioned, maybe in your first 1 or 2 years. And that makes you then eligible for the principal clinical scientist role. And that exam is mostly about fundamental and clinical immunology itself. So that was 2 3-hour exams. Probably, I would say, from personal experience, the most challenging out the whole process, but a really valuable experience nonetheless. And it does set you up to then step up into that principal clinical scientist role. It gives you the tools to be able to address that change in responsibility. The second set of exams, the part 2 exams they're called, they're almost like, I almost see them as like a bit of an exit exam of your training. It's like your entry into consultant level practice, and these exams are set up to make sure that you can practice safely and competently at consultant level, and that you're a safe pair of hands, but also that you can oversee a clinical laboratory, which is what your FRC path qualification kind of demonstrates. So that's 2 separate exams. There's a practical element of that, which is 6 1-hour exams all in one day. And those 1-hour exams are broken down into the various sections of the laboratory. So like Kavindi spoke about protein chemistry, there's an exam for that, and there's an exam for autoimmunity, etc. The second exam is a viva, where you're given 4 cases, and then you have to go into a kind of viva assessment with 2 consultants usually, who then ask you further details and ask you more questions about those cases. And again, it's just about demonstrating you're a safe pair of hands. You can go out into the real world and you can practice at a consultant level. So very difficult exams, very challenging exams, but very, very valuable when you come out the other side of that as well. So that's the HSST route that I kind of whistle-stop tour of what I did as part of the HSST. But as I've mentioned, there are other routes based on history, experience. So everybody's pathway is slightly different. And as mentioned already, people come into STP and HSST with a lot of different backgrounds. So for example, if you're coming into the STP or the HSST and you already have a PhD, quite often that can be used. If we take HSST as an example, you might not have to then do the whole doctorate level project again. If the Royal College of Pathologists can approve that PhD as being relative to your chosen speciality, then you can use that as your project side of things. And all you would need to do to meet the portfolio evidence is to just do a short, small innovation project within your lab, which we do those types of things every day anyway. So it would be fairly straightforward to evidence that. The other thing is that it is also possible to progress to consultant level without actually undertaking the HSST. If you wanted to progress without that kind of infrastructure in place and do it in your own time and work towards it that way, it's possible. You can do those FRC path exams at a rate which suits you as you want to progress. You would need to submit a relevant PhD, but if you don't have one of those, you could also undertake a casebook, which is You take I think it's 5 or 8 cases that you've been involved in your routine practice, and you write those up and your role you had within it and the clinical significance of those cases. And that is then assessed by the Royal College of Pathologists. Although it's not essential to progress then to a consultant level position, it would be recommended that you undertake some form of clinical leadership and management course. Again, as mentioned already, it just gives you the tools to be able to step in at that grade which you're moving in at. So that again was a bit of an overview really of the HSST and how you could do that. Now, in terms of day-to-day work, I think this varies, depends on where you're at. Now, I work at Sheffield Teaching Hospitals, and what's really exciting about that is the immunology department here is also a protein reference unit. What that tends to mean is essentially we do all of the standard immunology-based tests that Kavindi's already touched on. But because we're a reference unit, we've got an element of kind of service development that we have, and that means that we've just got a lot more tests than what a standard immunology lab would have. This means then we've got a significantly larger repertoire of tests to manage and control and work through on a daily basis. So that keeps us very busy. What's exciting about being at a protein reference unit isn't just the opportunity to be continually involved in service development and bringing in new tests and seeing what's a hot topic at conferences and driving that change so we can offer it to our clinical service users. Often we could be the only site within the entire UK or even within Europe that provides a certain test. So we get a lot of referred work coming our way as well, which is, like I said, it's exciting and it's fun, but it's also quite challenging to manage. So that keeps us on our toes every day to try and make sure we're doing everything we can to get the service providers for those who request it. As Kavindi's touched on, not many days are the same. It really depends on what's happening, what's happened in the lab recently and what is changing recently and what new tests are coming in. It's very, very much a diverse role, which is exciting in its own way. As a bit of a brief overview of the day-to-day work, I suppose a big part of this role, as Kavindi's touched on, is you have oversight of that laboratory, and it's not just oversight of making sure the laboratory is working and everything's fine. You also have that clinical responsibility for the tests which are coming out of that lab. So we need to ensure that the test results we're given and the advice we're given and the interpretation that we're given is really clinically relevant and up to date. And essentially, it's what our service users need. And that's really exciting to try and stay on top of that. Naturally, with any kind of big process and anything, there's a lot of incidents that happen, some rather big, some pretty small. But our role within that is to understand the clinical impact of those incidents that happen and put things in place to stop them from recurring, or to improve our service in certain ways so we can keep ticking over the work that we do. Because it's a clinical lab, we have to practice to certain standards, and therefore a very large part of the clinical scientist role is about managing your accreditation. And again, there's a set of standards that our laboratories have to meet to be accredited and provide a clinical service. So everything we do and every change we make has to be linked back to these standards, and it's very much our responsibility to ensure that we're doing that and our tests are fit for purpose. On a regular basis, we get involved in the authorisation and the interpretation of results. That's just the way it happens. We give out clinical comments and advice and suggestions for further tests or further referral work for patients. That's our kind of part of our role within helping the patient pathway and giving the physicians out on the wards the information that's required. But regularly, we have so many user inquiries to deal with. So it could be the case, something as simple as a physician or a GP's got a result and they just need a little bit of help with interpretation, to somebody's got a result and it doesn't make sense in the patient pathway. Can we look into it a little bit more and just make sure everything's okay? So there's a lot of variability in what we can deal with, but it does keep you on your toes and it keeps your knowledge up to date, and it is a very, very rewarding role when you can get into it. Finally, one of the parts I really enjoy about this job is multidisciplinary team meetings. So multidisciplinary can mean a lot of things. In one sense, you could have an immunology multidisciplinary team meeting where you have not just medics, but you have scientists and you have nurses and you have radiology, for example, and that's your multidisciplinary team talking through complex cases and having an input into the outcome. But you can also have multidisciplinary team meetings across other disciplines within the hospital. So immunology is involved, as I've mentioned already, in so many different secondary care disciplines. So we could have MDTs with rheumatology department, with neurology department, with gastro, with hepatology, and it never ends. There's always a lot of kind of service development and participation that we can have within those patient pathways to help improve them for the better. In terms of the bigger picture, as I've kind of touched on, immunology in the context of all the disciplines within the Royal College of Pathologists, it is a small speciality, but it can have a big impact. And part of it does have a big impact. And part of it having a big impact involves a lot of the networks and the professional committees that are set up to try and help the national front, really the national professional network, and help us keep together. So we've got a couple of examples here. There's an Immunology Professionals Committee, which is mainly scientific, and that helps us drive the immunology healthcare setting to discuss current challenges, national changes, and how that impacts into our discipline. We've got the Clinical Immunology Professionals Network, which is linked with the BSI. Some of you may be aware of that already. And again, that just brings together the different elements of the immunology teams to include scientists, medics, nurses, and brings us together to discuss what's going on. So we have working committees out of those groups, which include participating in guideline writing, feeding back on changes in practice, liaising with other disciplines of what needs to change as well. And then we've got the British Society of Allergy and Clinical Immunology, which is a really helpful organisation, again, in bringing all those groups together to drive kind of research and help drive our practice and set standards of care. What's exciting about them practicing at a principal level and a consultant clinical scientist level is you're in that group of people who can then participate in these committees and sit on these panels and have that bigger national impact. One thing that I was going to just briefly talk about at the end, and it is linked with the bigger picture, is kind of specialist interests of mine. So throughout this development programme and this training career pathway to get where I've gotten to, it's been really exciting to understand which part of the systems I feel like I can affect and that I enjoy doing. And one of the things I've put a couple of examples of here is I enjoy helping support the users of our service request appropriate tests and tests that are going to help their patients. What's interesting in the clinical setting is that we can sometimes request tests, but we need to understand actually if you get that test result, is it going to impact on how you manage that patient? Or if you potentially get a spurious result, it could have a negative impact on this patient. So I've got these two examples here. The first one was a paper of a project that I was involved in when I was a principal clinical scientist in Plymouth. And what we did is we provided local support to primary care, which is our GPs, to make sure that what they requested is going to be helpful for the patient and for them to be able to manage the patient. And we managed to publish that and have a kind of innovative approach to doing that. And progressing through the HST is also now given a platform where actually we've translated that into this new guideline, which is currently out for consultation with the Royal College, but it's now impacting at a national level. I've managed to work with a couple of clinicians across the country, and we've built this best practice guidance, which can now hopefully influence GPs on a national level and get that message out there so that we can influence on patient management. So that's a really exciting special interest, which I hope to continue. Working at the Protein Reference Unit, we do often get other labs contacting us for advice on best practice and advice on tests, which are not often performed in other laboratories, and that's something that I do enjoy. Additionally, having recently gone through the HSST training and the exams and the STP, for example, another real specialist interest is teaching and training. And that includes being an STP training officer and a mentor for the national immunology, all of the national trainees. We have a mentorship group that supports the trainees through their training, and we meet once a year with the trainees and just offer a general forum for advice to check in on the trainees, make sure that there's support in place at their respective hospitals. And also, I've always regularly been involved in teaching medical students, which is a big interest of mine. Finally, having been through the FRC PATH exams, something that I've recently set up with a colleague who works in Plymouth is a training course to support medical registrars and clinical scientists who are going through that exam journey with the fellowship exams through the Royal College. And we set up a 3-day course twice a year, which people who are about to sit their exams can come and attend, and we can give some advice on experience of doing the exams and advice on exam technique, including what to expect on the day, because sometimes it's quite difficult to get that information. Before I pass over for the Q&A, I think the last thing, looks like the slide's kind of gone off the screen a little bit, but just if there's any medics among us, I just wanted to highlight this BSSEI initiative that's happening. So there's a scholarship programme that's available for F Foundation doctors and IMT trainees. If you can scan that QR code to see if you're eligible, or see if you want to apply for this medical scholarship scheme, but it's to try and support basically training, which is just another good example of some of the things that can be put in place by these organisations, which I discussed already. So with that, I'd like to thank you for listening and bring back our hosts.
Thank you very much. It was great. So let's address some questions. So the first question is, how do we enter the STP if we're currently pursuing Masters in Clinical Immunology? And that question is addressed to Kavindi, as they have sort of the same papers as you.
Okay, so to enter the STP, there's if you look on the National School of Healthcare Science website, there's a lot of information about how to apply for it. Since you are doing a Master's in Clinical Immunology, I think you do meet the minimum requirement for applying for it. So if you go to that, yeah, it should have all the information there.
Okay, the next question is, what is the expected salary after clearing the STP?
So when you're on the STP training, these are linked to the NHS Agenda for Change brackets, so you could easily find that online. So NHS Agenda for Change pay. When you're on the STP training, you're at a band 6 level. When you're a senior clinical scientist, you move into a band 7 typically. When you progress to a principal, you go into a 8A salary, and you can be a experienced principal and become an 8B as well. And then when you go to consultant grade, you typically start at an 8C, but can go on to an 8D or a band 9 as well. So just have a look online for those Agenda for Change pay brackets, and that'll show you. They've recently changed, which is why I can't think off the top of my head.
Thank you for your answer, Kristen. We have another question from an undergraduate student. So they ask, what are some key components of a strong application when you apply to the SCP in immunology? And they've also asked what types of undergrad experience you would recommend to look into or pursue to enhance their application. And it's for either one of you.
Okay, I would say demonstration of your understanding of how a clinical laboratory works. So understanding a little bit of what the role is, but generally, mainly how the lab works and what your impact on that would be on the patient pathway. So really sort of, yeah. And in terms of experience, the way you can do that is asking an immunology lab, if you're interested in immunology, whether you can shadow for a day, a week, however length of time as you want. I only spent an afternoon in an immunology lab, and I really used that and my understanding of it in my application. And I think it came across.
Yeah.
Certainly. I'll just add on that, if that's okay. Just having been involved in actually the shortlisting process as well, it really does stand out. So as Kavindi's mentioned, if you even just reach out to someone in a lab to talk to them and ask questions, make sure you mention that and put it in. If you manage to spend a day or two in there, great. If you can show that you're aware of a clinical laboratory and how it works, brilliant. But also a common problem that people fall into is they're not very specific about how they could impact. So there's often a trap you fall into where you say, I really want this job, I would be really good at it, I can do all these things, but actually it's about, yes, I really want this job, but here are specific examples of where my previous experience can impact on patient care, if that makes sense. And the examples you give, they don't have to be science related. There's people who've got examples of having done some volunteering or examples from their part-time job anywhere, and just show how what they've done and they've thought about has had a direct impact, and why that would then benefit the NHS as a clinical scientist.
So another question is, could you please recommend some clinical leadership or management courses? And it's again for either of you.
So I Good one. There's a few online courses which you can do. They typically cost a little bit of money. They can cost a little bit of money. And I can't remember the name of it off the top of my head, but it's a well-established one. But I'm sure if you look on Google or whatever, you'd be able to see a whole lot of options that would be available to you. Um, like I said, if you do go into the scientist training route through the National School of Healthcare Sciences, they would signpost you to a lot of this as required.
Thank you, Kristen. Our next question, well, I'd like to merge these two questions because they're quite similar, is someone's asked, is if immunology is not very patient facing, what does clinical practice involve for consultant clinical scientists? And the other question, which I'd like to, merge along with this because it is along the same lines, is as clinical scientists, is all your time spent in the lab, or do you also see patients?
Okay, so I can take the first part of that question. Yes, so the clinical part of the role, which is the interesting one, is we can interpret the test results and quite often complex test results, and offer a suggestion towards patient management or an explanation behind those results, or what if the patient's had treatment is what these results represent. So that's one element of the clinical practice. The other element of the clinical practice, as you've kind of touched on, is the direct contact with other clinicians and physicians who do see the patient. So quite often, if we have abnormal results, we'll contact the person who's requested that result and have a discussion around the case. How did the patient present? Have they had any medication, etc.? And that's where the clinical practice comes in on a day-to-day basis. But as I've mentioned, there is that role where your clinical practice comes with writing guidance and writing guidelines, which are then used within the healthcare setting. So that's a really large element of it itself. And apologies, could you repeat the second part of that question? I think Kavindi might be good for this
Yeah,
part.
no, that's all right. The second part was just about do you actually see patients as a clinical scientist, or is it again more of a behind the scenes, non-patient facing role?
Yeah, I would say it's definitely in immunology, at least it's not usually patient facing. I think most pathology disciplines are the same. Although there are some roles for certain specialities where they're beginning to become more patient facing, but not immunology as far as I know.
Okay, and the last questions, we'll just merge them together for time reasons. Can you choose your location when you're applying for STPs, or are you randomly allocated? And what are the shift patterns like? Is it the 9 to 5 or, more flexible?
So I can take that one. So when I applied, and I don't know if it's still the same, but I presume it is, how it works is you choose the locations that you're willing to relocate to, and then you're assigned a location based on your ranking, on your application score and your interview score. I don't know if you know any different, Kristen.
No, that's about right. You can only select a preference, especially for the direct entry route. You can select a preference and it's allocated based on performance at interview and application. That would be slightly different if it's an in-service route. So that's because you'd be already employed at a hospital and that hospital is putting out that expression of interest which you can apply to. So it's one of the difficult parts about it is you don't have a lot of control over that.
Yeah, and for the second part of that question, the shift pattern is normally Monday to Friday, 9 to 5:30.
Should we pass to Penny now? Because the time is kind of tight right now.
Thank you so much, Victoria. Yeah, so we're just going slightly over time. Just want to say thank you so much to our speakers and hosts. I've got a couple more slides just at the end. So okay, so we're going to I'll send you a feedback survey. So yeah, please just give us your feedback. It'll be a short online questionnaire. I'll send that by email. And we'll also put in the follow-up email some information about all the links that we've mentioned. So the National School of Healthcare Science, plus our careers pages, and also our social media links. But I just want to say a huge thanks to our two speakers, Kristen and Kavindi, and to our fantastic hosts, Victoria and Hargreave. So thanks everyone for listening.